Good day everyone. I am Dr. Sundeep Hegde, Senior Professor, Department of Pediatric Dentistry, Pediatric and Preventive Dentistry, Yenepoya Dental College. Today I will be talking about a very relevant topic in clinical dentistry, that is behavior management in pediatric dentistry. Here I am putting a slide of a pediatric dental clinic waiting room. This is actually the waiting room of our alumni, Dr. Fardeen, who is a exclusive pediatric dentist in Pune. You can see all the colorful toys and colorful caricatures and colorful chairs which are there in the waiting room. This is to exactly make the child be happy when they enter the dental clinic. As you are all aware of, children basically are very scared of going for the dental treatment. Actually, it is a general feeling that treating a child is a very difficult task. If you ask me, definitely it's a big no. I think with proper behavior management techniques, I think you can manage the child very well in the pediatric dental clinic. Dental anxiety can affect anyone, but children are particularly very susceptible. Dental fear and anxiety is a common reason for avoiding dental treatment, which over time may result in deteriorated oral health. It is a complicated and multifactorial etiology. What do you mean by behavior? Behavior is any activity that can be observed, recorded and measured. It is an observable act or any change in the functioning of an organism. There are numerous researchers who have done a lot of research and work on studying the behavior of the child, and they have proposed many classifications. One of the earliest classification was proposed by Frankel in 1962. It is also called as Frankel's behavioral rating scale with Wright's modification. He divided the child's behavior into 4 categories: rating 1, rating 2, rating 3 and rating 4. According to him, the children who belong to rating 1 are definitely negative. You can see the double minus inside the bracket, that is the Wright's modification. This definitely negative children have refused the treatment, cry forcefully, and they exhibit extreme negativism. The child who comes under the rating 2 are negative, exhibit negative behavior. They have difficulty to accept the treatment and they are quite uncooperative children. The child who belongs to rating 3 exhibit a positive behavior. The features of rating 3 are acceptance of treatment, willingness to follow the dentist instruction, may be hesitant too. Rating 4 is definitely positive, that is plus. They have a very good rapport with the dentist, will enjoy the procedure. Usually the child who belong to rating 4 are the ones who dentists love to treat. It is not so. With proper behavior modification, behavior management techniques, all the ratings can come under rating 4. Next, in 1970, Lampshire proposed a classification of behavior. He put the children's behavior under the following categories. First is cooperative behavior. As the name suggests, the child is physically and emotionally relaxed, is cooperative throughout the entire procedure. Tense cooperative, the child is tense and cooperative at the same time. Outwardly apprehensive, avoids the dental treatment initially, usually hides behind the mother, avoids looking and talking to the dentist. Eventually they will become good patients, eventually accept the dental treatment. Fearful, they require considerable support so as to overcome the fears of dental treatment. Stubborn children, they usually passively resist treatment by using techniques that have been successful in other situations. Hypermotive, child is acutely agitated and resorts to screaming and kicking, etc. These are extremely negative behavior children. Next is handicapped, physically, mentally and emotionally handicapped. The last one is emotionally immature. Next, after 5 years, Wright, who has done a lot of work and lot of research on studying the behavior of the child, put the behavior of the child under two broad categories, that is cooperative and uncooperative. Cooperative meaning positive behavior, uncooperative meaning negative behavior. Under cooperative behavior, he put the behavior of the child under three headings. One is cooperative, lacking cooperative ability, and potentially cooperative. As the name suggests, cooperative behavior, the child is cooperative. Lacking cooperative behavior, it is usually seen in very young children, 0 to up till the age of 3 years. Usually very small young children are unable to understand the instructions of the dentist, so they are lacking the cooperative ability. Disabled children, physical and mentally handicapped. Next is potentially cooperative. These type of children have the potential to cooperate, but because of inherent fears, that is subjective and objective fear, they are not able to cooperate. Subjective fear is something which the child would have heard from others. Objective fear is something which the child would have experienced by himself or herself. Under uncooperative, Wright classified the child's behavior. First is uncontrolled hysterical behavior, usually seen in preschool children in their first dental visit. Temper tantrums, that is physically lashing out of legs and arms, loud crying, and refuses to cooperate with the dentist. These are very uncooperative children. Defiant, obstinate behavior, it can be seen in any age group, usually seen in stubborn children. These children can be made cooperative after proper behavior management technique. Tense cooperative behavior is the borderline between positive and negative behavior, does not resist the treatment but is tense at times. Timid behavior, it is also called as timid child. It is seen in children who are overprotected by the parents. It is usually seen in the first visit. These children are usually shy but are cooperative. Whining type of behavior are the children who are of complaining type of behavior. They allow for the treatment but complains throughout the procedure. They will be making some sound during the procedure. They will be crying continuously or something, but they will ultimately allow for the treatment. Stoic behavior is seen in physically abused children. They are quite cooperative children and passively accept all the treatment without any facial expressions. Now, what is behavior management? Behavior management is something which has to be employed by the dentist to treat the child. That is the first step in the treatment of a pediatric dental patient. Gerald Wright in 1975 has given a wonderful and a very meaningful definition of behavior management, where he says behavior management is the means by which the dental health team effectively and efficiently performs the treatment for a child and at the same time instills a positive dental attitude. What he exactly means is, it is not only the duty of the dental health team to perform the treatment efficiently but also instill a positive dental attitude. The child should be very happy to come back to your dental clinic again. What are the objectives of behavior management? The objectives of behavior management, first is to establish effective communication with the child and parent. Only effective communication, the dentist can put all the treatment plans across to the child and the parent to gain the confidence of the child and the parent, to teach the child and the parent the positive aspects of preventive dental care. It is the duty of the dentist not only to do the proper treatment but also to instill a proper preventive protocol so that the future dental diseases are prevented, to provide a relaxing and comfortable environment for the dental team to work while treating the child. Behavior management can be pharmacological and non-pharmacological. Pharmacological is something which you do the behavior management with the use of drugs. Under pharmacological, conscious sedation, deep sedation and general anesthesia procedures will come. Under non-pharmacological behavior management techniques, there are multiple methods which can be used. There is modeling, there is home and communication, tell-show-do technique, distraction and positive reinforcement. Here I'll be mainly talking about communication, tell-show-do technique, distraction and positive reinforcement, which are some of the easiest techniques which can be employed by the dentist to treat the to do the behavior management of the child. Under these using these 3-4 methods for non-pharmacological methods, the dentist can, most of the children can be managed very easily and a proper dental treatment can be done. Communication. Communication should be comfortable and in a very relaxed atmosphere. Language used by the dentist should contain words that express pleasantness, friendship and concern. Voice that is used should be constant and gentle. The dentist has to make sure that he or she should not talk very fast and should not raise the volume of the voice. The tone of the voice can express empathy. It is not only expressing empathy, the dentist tone of the voice should be little firm also, which is very important in controlling the child during the dental treatment. Sitting and speaking in the eye level allows for a more friendlier atmosphere. It is the dentist, as far as possible, should avoid standing and talking to the patient. It's better to come to the eye level of the pediatric patient and talk to the patient. Use of euphemisms. Euphemisms are substitute words which can be used in the presence of children. For example, if you are going to give a local anesthesia, anesthetic solution can be referred as a water which is going to put the teeth to sleep. Caries can be referred as a tooth bug. You can tell the child that I am going to remove the tooth bug from your teeth. Rubber dam can be referred as raincoat, because most of the times when using the rubber dam, the child becomes a cooperative child will become uncooperative. So it's better you use euphemism, tell that I am going to put a raincoat on your tooth and the child will become cooperative. Radiograph, if you are taking a radiograph of a child, you can take that I am going to take a tooth picture of your tooth. Aerator can be referred as a whistle. First I will be mentioning about tell-show-do technique. Edelston, Harold Edelston in 1959, he proposed this technique. You have to tell and show every step and instrument and explain what is going to be done. The main indication, it is also called as TSD. Tell-show-do technique is also called as TSD. Indications for tell-show-do technique is usually it is done in the first visit, subsequent visit when introducing a new dental procedure. What I meant is, suppose if you are doing a tell-show-do technique for a oral prophylaxis procedure or a scaling procedure in the first sitting, if you are doing a restoration in the second sitting, you have to repeat the tell-show-do technique pertaining to the restorative techniques. It is usually done in a fearful child. Now I am showing a video, small video, which is demonstrating the tell-show-do technique. Here one of our doctors is trying to tell the child what exactly she is going to do. She is explaining what is a mouth mirror. She is giving the mouth mirror in the child's hand and she is using the mouth mirror in the mouth. The child knows what exactly the dentist is going to do. She is explaining the procedure to the child. Basically, she is going to do a restoration here. So she is going to show all the instruments which are being used for the restoration. Yeah, now she is showing the aerator, giving the aerator in the child's hand and showing the water spray, because most of the time the child become very apprehensive or fearful when the water spray is there. Now the child is comfortable. The child knows exactly what the doctor is going to do. Yeah, next step, next behavior management technique is distraction. This is one of the most commonly and most very efficient method which can be used in the pediatric dental clinic. Distraction is a method that helps a child focus attention on a preferred activity in order to think less about another less desirable activity. Distraction helps the children to be less anxious and more relaxed. There are different types of distraction. One is audio distraction and audio visual distraction. I'll be showing a small video regarding the distraction techniques. Here, distraction technique demonstration is being done. The dentist is explaining using the tell show do technique. Basically she is going to give a local anesthesia procedure for this patient. Usually children are very scared about local anesthetic injection. So she is demonstrating, trying to make the child relaxed, talking continuously to the patient. The dentist is being helped. So she is explaining to the child, assuring the child what exactly to be done. So basically it's the tell show do technique, communication technique, which is being followed right now in the video. She is going to place the cotton. She is going to explain that she is going to, basically the dentist is using a local anesthetic gel before giving the local anesthetic injection, trying to make the child very relaxed, which goes a long way in the treatment, a good treatment of the child. Now she is placing a local anesthetic gel before giving the local anesthetic injection, continuously talking to the patient, assuring the patient that she'll be all right. Meanwhile, she is handed over an audio-visual clip which shows an animated movie. The child is distracted. Child is concentrating on the audio-visual clip which is given to her. Meanwhile, continuously the dentist is talking to the child, assuring the child that she will be okay. Now the distracted child is immersed in watching the animated movie. The dentist is using the local anesthesia. Child is distracted. Now the video is handed over to another dentist who is distracting the child. Child is very relaxed because communication, tell show do technique and audio visual distraction is in play. Basically the dentist successfully, without causing any apprehension to the patient, child patient, she has given the local anesthesia. Whereas continuously the child is immersed in audio visual distraction technique. The next behavior management techniques, what I am going to talk about is the positive reinforcement technique. It is the management of modifying the behavior of the child by presentation of reinforcer. Positive reinforcers is one whose contingent presentation increases the frequency of behavior. I will be showing a small video clip where positive reinforcement is demonstrated. Here the dentist is polishing the tooth after the oral prophylaxis. The child is very cooperative after a proper behavior management technique. Child is happily undergoing the treatment. Dental treatment is being done without the child being fearful. Once the treatment is done, The child is appreciated for his good behavior, and the child is presented with a small reward, a sticker, which is given to the child. Child is very happy. Even the child's elder brother is excited looking at the reward. The dentist explains to the child that he has been a good patient. Next time also he has to behave in the same way. So this is how you reinforce a good behavior. We have to reward the child after the treatment. In the process of establishing a desirable patient behavior, it is essential to give appropriate feedback. What I mean is, once the child exhibits a good behavior, it is essential to tell the patient that the patient has undergone, the patient has exhibited a very good behavior, and this good behavior has to be repeated in the subsequent appointments. Positive reinforcement is an effective technique to reward desired behaviors and thus strengthen the recurrence of those desired positive behaviors. I would like to end my presentation by a wonderful quote by McElroy, who mentioned that although the operative dentistry may be perfect, but appointment is a failure if the child departs in tears. What exactly he meant was, the child should be happy in the dental clinic after a proper behavior management technique, and the child should be happy to come to your dental clinic once again. A happy pediatric dental patient in the childhood becomes a good adult patient of tomorrow. I would like to acknowledge Dr. Shobhan Dandan, who is my teacher, and Dr. Nikhil Marwa, who is my good friend. I also would like to acknowledge Dr. Manisha, Dr. Yashovardhini, and Dr. Bharati for helping me with this presentation. Thank you very much. Have a wonderful day.